Our first speaker is Damian Roland, who you already met. He is a PEM consultant and chair of Peruki. Damian, welcome.
So, good afternoon, everyone. I am not Rachel Roland. Different surname, different person. Unfortunately, Rachel's son injured himself yesterday, and she's needed to go back to Leicester. So I have taken up the mantle. We had discussed this talk in advance, and this is Rachel's talk. To make sure that it has makes sense to me, I've made some alterations, but I need to attribute Rachel as the primary author here. As Katie said, this is going to try and be a session about a hint to guidelines and a hint to the evidence base. But my perception is that actually, in the real world of clinical medicine, we are faced with challenges. And the challenge is the child in front of you and what the evidence tells you should do versus what you may like to do. And that creates conflict. And it creates conflict specifically in sepsis. And this is a great quote from a couple of years ago. And I think most people will feel the uncomfortable reality of this particular statement. Ed Snelson and I have a different way of looking at this, but it's the same theory, is that we all know the most likely thing is that the hot, febrile child in front of you is going to be well and has a self-limiting illness, but there is that evil twin. And our jobs, whether you work in the emergency department or on the wards or in urgent care centres or outside of the hospital, is spotting the evil twins. So this is baby Barney. Now, baby Barney is 6 weeks old. There's no really relevant past medical history. Baby Barney comes in and has a high temperature. There's a respiratory rate that is not uncomfortably high for his age, feels warm, is crying during the assessment of heart rate, and is marginally tachycardic or not, depending on which heart rate guideline you look at. And so we have a question. The website is above you. What I would like for you to do is just based on that information, and I'll give you a bit of time to log on, is what are you going to do? What is your preferred choice out of the list that is given there? With the numbers, it's interesting. Very small deviations suddenly make a massive difference to the percentage rate. But I think we're settling towards about half of you thinking about a partial septic screen and a third doing a full septic screen. Okay. Now, if we reduce the age to 3 weeks, just same question again. Okay, so small variations aren't going to change that. It's overwhelmingly, with exactly the same clinical information, a change of 21 days completely transforms this audience's perception of risk and the investigations they'd like to do. And in my practice, exactly the same things happens, is that when you go below 6 weeks, the evidence and our own clinical intuition supports the fact that there is something underlying nastiness that you're just not willing to miss. And so we will potentially over-investigate that group, but for good reason, because 10% of that group will have a serious bacterial illness. Now, that serious bacterial illness definition does include urinary tract infection, and it is a matter of debate about whether a simple UTI in a neonate is a true invasive bacterial infection or not. But we've all seen the child who has a simple UTI go on to become potentially septicemic, if we still believe in that word, and very unwell. So this is a high-risk bundle, and in my practice, I would do the same thing. So when you go over 6 weeks, you've got a bit of a decision to make, but I err on the side of caution. But below 6 weeks, these are not difficult decisions. The febrile neonate is going to get a whole host of investigations, and now what we're waiting for is the big research groups in America and Europe have invented a number of approaches where we use biomarkers and clinical intuition to make decisions. And my suspicion is over the next 5 years, when some of those decision rules like fever step, etc., are validated in external settings, we may start seeing a push for more tests like procalcitonin, specifically for this small group to aid our decision making. But that is actually the easy part of this conundrum. Sepsis has become a ubiquitous word in pediatrics. And there are a number of statements that can be made about sepsis. And I would argue that all of those on this particular page are probably a work of fiction. And I want to address those works of fiction, but there's 2 phases to them. The first phase is the assessment or pre-investigation phase, and a bit about the height of the fever. There is a modicum of evidence that if you have 1,000 children, in those 1,000 children, if you have a temperature of 38.5 degrees, your chance of having pneumonia is going to be 2 or 3 patients in that group. If you have a temperature of 39.5 degrees, it probably goes up to 5 or 6. So there is something about the temperature itself that may increase your risk, but the numbers are tiny, and it is not worth thinking about temperature itself or its height as a measure of what you've got underlying it. But what really matters, and I think this is a dissonance between subjective findings, so these are things like, does the child look unwell? Have they got a color change? Is there mottling? Is their behavior different? To objective things, the actual heart rate, the actual respiratory rate. And it's a bit weird. Most times in medicine, it's objectivity that we're looking for. But when we're thinking about screening children for sepsis or making a decision-making, it's actually the appearance that often trumps physiology. So if we had this child in front of us, the way he's looking at you, if he came up with a really high heart rate, you check that heart rate again, because that would be dissonant to you. And in my practice, I am much more concerned about the child that I think looks unwell rather than the child who is objectively physiologically unwell. Yeah, okay, I'm not going to ignore a heart rate of 210, obviously, but I'm not so fussed about 160 to 180 if there are no other subjective signs of illness. And it's difficult because our guidance at the moment, especially in the UK, the NICE sepsis guidance, actually gives us clear parameters. If you look unwell, you're mottled, you are unresponsive to normal factors, yes, that is a red flag sepsis screen jump in. But also, if your heart rate is above 160, if you're under 2, if you have a high respiratory rate, that's also a red flag as an independent factor. And that troubles me as a clinician because that doesn't marry with what I see on the shop floor. Then there's a whole load of investigative tests. And those investigative tests come with a loaded problem. We don't really know what positive is. There is no magic number for CPR. There is no blood culture time. There's been a great debate kind of recently of people showing the evidence of actually how much blood you need in your blood culture bottle. Okay? We're used to trying to get a tiny bit out, stick it in. For every mil that you put in the blood culture, your chance of actually finding something increases rapidly. And yet we tend to ignore that when we're looking at stopping antibiotics or deciding whether to initiate treatment. All positive results aren't the same, and especially for sepsis, there is no magic number, and that causes us a challenge. And it creates this dilemma for us, because I think everyone in the room If you see someone you're sure is completely well, then we're happy with that. The moribund, mottled child who comes in with purpura fulminans, that's not difficult either. It's the group in the middle, and the group in the middle are the high-risk group because we're not sure which way that the seesaw goes. If you choose to make a decision where you don't treat, that child may come to harm. But just treating everyone clearly causes problems for unnecessary admissions and antimicrobial resistance. And there's a particular issue that we have in our local institution, because we have been subject to a number of high-profile cases where children have come to harm as a result of a delayed or misdiagnosis in sepsis. And that weighs on people's minds. It weighs on the department's minds, it weighs on the clinical staff's minds, it weighs on other parents' minds. And that alters our decision-making process, and it makes it very uncomfortable. I suspect there are large variations in the management of sepsis, depending on that unit's organizational memory of the mistakes they have made previously. And that's not written down in any guideline, doesn't come in the textbooks, but it's there. It pervades everything that we do. And there are children nationally who have really raised the profile of sepsis, but through tragedy. But it is a testament to the hard work of the families of children that we've let down that I'm probably even having this conversation. And in order to move their memory forward, we need to make sure that we are doing the right thing as often as we can. But no one contextualizes some of this tragedy or this the feeling of letdown and hurt that some people have had in our normal practice. And thank you to the UK Sepsis Trust. I think Ron Daniels, who is their lead, has done a significant amount of work in raising awareness. There are things where the organization have put out information that has sometimes conflicted with the medical practice of doctors and nurses. But at the heart, this organization wants to make sure that everyone is aware of this devastating condition. And to be fair to them, they must have saved lives, both pediatric and adult, in doing that. So we're left with gut feeling, intuition. And we know that that isn't always particularly reliable. So in our particular department, there are a couple of things that we've done to try and improve things, to help people to be clinical superheroes. That's Rachel on the right is Spider-Man, I'm Banana Man on the left-hand side. So the process starts at our front door. When you walk in, we have what's called a DPS, a dynamic priority scoring system. It's really simple. It's essentially everyone is a 3. Unless you're a 1, but you virtually never get put down as a 1, because if you're a 1, you're at death's door and you get pulled straight through. There's no time to put you as a 1 on the computer. And you're not a 3, essentially, if you're less than 3 months old or you have an obvious deformity. It's a very simple system. It's a 1, 2, or 3. And so that those children who we perceive as being most high risk, that younger age group, will immediately be prioritized for the assessment queue. So if we have, and we do sometimes have 30 children an hour present, those ones at most high risk will be assessed first. We have clear screening criteria. Now, this isn't perfect, and for precisely the reasons I've mentioned, breathing and circulation requirements conflict with how the child appears. And there's work to be done, there's evidence to be gained, and we need to use different methodologies and techniques to improve the way we stratify that original risk. But what we like to do is make sure that we're recording our decision-making. And that's why on the second page, there is a big de-escalation box. We're not saying you have to treat every child, but please record your reasons why. We have a sepsis box. So this box contains clear guidance, drug doses, and the drugs themselves. And all you need to do is run out, find the box, And when you've got that by the patient's bedside, or you've got it with the nurses so they can start drawing those medications up. This is a really simple intervention. It's going to save you maybe 5, maybe 10 minutes, maybe not a lot, but it will save you something. Rachel's actually quite an advocate of looking at teenagers and young people in terms of the way that they present, mainly because she sits on our child death overview panel. And some of the tragedies that we've had for children dying are in this older group. And it's interesting, there's this mantra that children are able to resist quite significant illnesses and won't drop their blood pressure until the very end. But that applies into adolescence as well. And we've had cases of teenagers walking into the department with a fever, a mild tachycardia, and then being in the resus room within an hour. And they are a group, and just because they're able to text and speak to you at the very beginning doesn't necessarily mean that something is evolving over time. We are ingrained in our approach to treating fever. We are clear in our department that you are treating fever not because you're trying to get the temperature itself down, you are managing a child's distress. And when you have managed a child's distress, it may help you make a decision about the observations. You're looking for normalization. It's conflicting to me because there is absolutely no evidence that supports that at all. No one has ever published anything that says if you take a child at one end who is tachycardic and febrile, you give them some ibuprofen and paracetamol, and the resolution of those OBS means you don't have a serious bacterial illness. We're looking for that evidence, and we need to do that study, but it's not there yet. But that's what we practice because you get a very different child very quickly. It is important that you document things. I have something very morbid called the brought back dead test. If I'm discharging a child who has a simple viral illness, I think to myself very quickly, what happens if this child comes back dead tomorrow morning from sepsis? And I look back through what I've written. Does what I have written accord with the decision I'm making now? Have I made sure I have described how the child looks? Make sure their observations are recording. Make sure that change is being recorded and that I can document the parents are happy with the decision to go home. Because actually, most of what we deal with is very simple infections, but the consequences of missing something serious are life-changing for everyone involved. And my finest practice point is actually what I rely on most is not physiology, it's not how the child looks, it's my discussion with the parents. Do the parents understand risk? Are they engaged with me? And have I made sure that their concerns are completely addressed? Because actually, those children on the borderline, if the parents understand the evolution of disease, if they're happy at the moment that they feel their child is improved and they trust me as a clinician, I think that's a safe child in order not to make an antibiotic delivery decision on. But the numbers of that child might be contrary to national guidance. But I personally think that is the safest way of approaching this problem is by collaboration with parents. Thank you very much for your time.
Thank you so much, Damian. That was very insightful. Before we go to Twitter, I just wanted to ask for myself, if you have if you choose to deviate from a guideline and parents are very clued up and challenge you on that, how do you deal with that situation?
So there's two ways that works. So there's the very anxious, or sometimes angry parent who has a child who, by any measure, guideline otherwise, is well, and that there is a phobia element to that. And that, to me, needs observation, that child is not going to go home until that conflict has been resolved. There is a different challenge, I suppose, about when there is some abnormality in the child, whereas your gut feeling is actually this is going to be okay, and there is a discussion to be had. There are children who I have decided to admit, investigate, treat, potentially against what my gestalt tells me is the likely outcome going to be, because as the life-changing thing shows, I can't make that decision against the parents' best wishes. It's that collaboration. It gets more uncomfortable in the middle, whereby there's tension on both sides, and I think we're just learning that. My personal feeling is we need to work much harder with the public on their understanding of risk, especially around the evolution of disease and sepsis, because the evidence is quite clear. There are some children who will present on one day and they have a virus, and they present 2 days later, and that is a new bacterial infection. And I don't think that message is clear to the public.
Yeah, absolutely. Thank you. Anything from Twitter, Becky?
There's a few questions. First question is from Edward Snelson. There's been no published evidence that the introduction of the NICE guidelines for sepsis has improved sepsis recognition. Do you know of any plans to evaluate whether these guidelines have been improved or to improve them, or whether the guidelines have improved or possibly worsened our sensitivity/specificity of identifying sepsis?
Yeah, so that's good. So there's two parts of that. So for those of you not in the UK, so NICE, National Institute for Clinical Excellence, is our national, and it's a regulated, it's written into law that NICE tell us what we should be doing. Now, NICE were formed on some key constructs. One of those is that they make crystal clear what subjects they're going to look at and how they're going to assess those. And one of the things that they do is they do evidence reviews every couple of years. And they put out a commissioning call for people to look, is there new evidence, and should we review this? And we're all really busy clinicians, and actually very few people respond to that. And what sometimes happens is that NICE, if no one feeds back to them that there's nothing new, or they don't think that there is something new, they will just plow on. Now, I think there's overwhelming evidence, or at least overwhelming papers that have been written that show that our current screening criteria based on heart rate and respiratory rate is so poorly specific and poorly sensitive that we need to review the whole system, but they can only do that when they formally ask for that evidence. So if you're in the UK, look out for when that call goes out. There are at least 3 research groups looking specifically at this question, but they've just not published yet. There's a number of local case studies, especially from Newcastle, and I think one from London, showing how essentially 40% of children meet the criteria if you're in a group that's febrile and look a bit miserable when you arrive. And if tachycardia is your only problem, and with fever, I think that should be removed as a red flag, personally.
Well, actually, I think you just answered several of the questions that were asked, a lot about fever, and once we treat it and they settle. But there's another one from Emily Pascoe. What is your personal practice regarding tachycardia out of proportion to the fever? For example, every degree Celsius above 37 and a heart rate increase of 20.
So I don't use that, or I don't think I use it in that way. I look at a child, and if they are febrile and have a tachycardia, I try and remove the temperature element to see what happens to the heart rate. The other thing I make sure of is if there is a persistent tachycardia, is that the person doing the observation has done that in the best possible way. So sometimes it is virtually impossible to do a heart rate properly, and we have some amazing nursing staff and healthcare assistants in our department who can work magic on virtually any child to get some observations. But there are a smaller group of children who are quite resistant, and leaving a SATS probe on for a period of time until they get used to it, and you just wander past watching what their heart rate's doing. And you can see over time whether this is truly a raised heart rate or something that is ebbing and flowing. One of the other things that is visually important is that we have an electronic observation system in our department that displays the numbers as a grid. And it's quite useful to see because you can see the trends together, is that the heart rate and temperature coming together. Now, again, there is no evidence to support this at all, but when the heart rate and temp are in sync, I'm less concerned. The only thing that can confuse you with that is pneumonias, because pneumonias often go up and down. I'm of the principle that pneumonia is not sepsis, or a chest infection is not sepsis, and we have this, unfortunately, because of this heart rate criteria, you are not allowed at the moment to have a significant heart rate and a temperature and just be an infection. For some reason, over the last 5 years, you're not allowed to be diagnosed with just a lower respiratory tract infection, just meningitis. I say just, but just meningitis or just a UTI. It has to be sepsis or no sepsis. And I think that damages our clinical decision-making.
Thank you. Is there anything from the audience? Yeah, we've got a roving mic at the back. Oh, no, we don't. I will hop off the stage myself.
Thanks very much. I was just going to make a comment about children going home. I think one of the biggest problems is the language we use when we send children with fever home. And if we use the wrong language, the biggest danger is that the parents might believe us. And I always try to avoid using the word viral infection because they may believe us, and if it actually is an early bacteremia that's evolving, then that can be a terrible outcome. So I think it's much better to say your child has an infection, there's no sign of anything serious here at the moment, but I don't know what the diagnosis is. So if things change, bring your child back.
100% endorse.
Thank you. Anything else from the audience?
Hi, Lauren from Melbourne. A lot of the sepsis guidelines work on the assumption that children are immunised, and in the era of increasing lack of immunisation of some of our children, does that change the way you approach the febrile child?
Definitely. One of the issues that we have is a lot of data about the way we pick up sepsis is on different immunised groups, and immunisations actually do not infrequently change, i.e. every couple of years there might be something new added in, so research that was done 10 years ago isn't applicable to your cohort, and that works both for new vaccinations and maybe increasing non-vaccination. And that's why we'll still be talking about this in a decade's time, because there'll be some new scare or some new vaccine that comes in that completely changes the pre-probability of the risk. So it's a very good point.
Thanks very much, everyone. I'm sure we could actually discuss this all afternoon, but we've got two other fantastic speakers. So join me in thanking Damian.